Welcome to the second in the eating disorder series, this one focused on treatment. Today we're going to look at the different components of treating patients with eating disorders, including recognizing the potential for medical complications, facilitating weight restoration, addressing psychological issues, and the role of pharmacological interventions. In the previous talk, we described how to screen and diagnose these patients. Once you've identified a patient with an eating disorder, it is important to connect them with the care that they need, as earlier diagnosis and treatment is associated with better outcomes. Caring for a patient with an eating disorder is a team sport. Key players include the primary care provider, a therapist, and a nutritionist. Some patients may also really benefit from the inclusion of a psychiatrist, but this actually isn't necessary in all cases. One of the first steps in treatment of these patients is a thorough medical evaluation. All eating disorders have possible medical sequelae, and today we're going to focus on some of the consequences of anorexia and bulimia. When you're managing these patients, it's important to take into consideration the physical toll eating disorders can take. For anorexia, these complications are usually related to organ dysfunction due to malnutrition and the patient being underweight, as starvation affects all organs of the body. With bulimia, the specific complications are typically related to the form and frequency of purging. It's also important to recognize that for those with anorexia who also binge and purge, that they may suffer from complications seen in both of these illnesses. The most deadly of these are often the cardiac complications. In anorexia, a third of the deaths are the result of cardiac issues. These patients often have increased vagal tone, and you subsequently see bradycardia, orthostatic hypotension, and syncope. They can also suffer from arrhythmias and congestive heart failure. Patients with bulimia can also experience cardiac symptoms, particularly as the result of hypokalemia that comes from purging. For those using Ipecac, they are at increased risk of Ipecac-induced cardiomyopathy. Those with eating disorders can also experience significant GI symptoms. While some are the consequence of starvation or binging and purging, these symptoms also often perpetuate the maladaptive patterns, as patients tend to find themselves feeling more uncomfortable and bloated after eating, leading to further restriction and purging behaviors. Again, we see that the complications with bulimia are related to the form of purging they use, whether that's vomiting or laxatives. Endocrine issues tend to be more severe in anorexia as they suffer from the consequences of severely low weight, which can lead to dysregulation of a number of hormonal systems. Interestingly, those with bulimia seem to be at increased risk for polycystic ovarian syndrome for reasons that are poorly understood. It's also important to consider electrolyte imbalances. I want to emphasize that in anorexia, someone can be extremely underweight and still have stone-cold normal electrolytes. I have a patient right now with a BMI just over 14 with completely normal labs. These are just not a good marker of illness severity. Hypophosphatemia most often occurs in the setting of refeeding syndrome, which we'll discuss later. Patients with bulimia are actually more prone to electrolyte imbalances due to the shifts that come with purging, including hypokalemia, hyponatremia, hypochloremia, and metabolic alkalosis. Understanding a patient's medical complications helps us to decide where the patient should undergo treatment. There's a range of settings in which to treat eating disorders. On one end of the spectrum is outpatient. Those requiring more support, though, may benefit from a more intense level of care, and those that are unstable from a medical or psychiatric standpoint may require inpatient hospitalization, either for psychiatric or medical reasons. Having considered the medical complications, how do you go about treating the eating disorder itself? Treatment involves a number of components. The first step for those underweight is weight restoration. We then work to address eating disordered thoughts and behaviors, both directly and through psychotherapy. Finally, in some patients, psychotropic medications can help facilitate recovery. This can feel like an uphill climb, and it's important to recognize that treatment is not always linear. Taking 2 steps forward and then 1 or 3 back is pretty common with these illnesses, so patience and realistic expectations are important for both you and the patient. For those who are underweight at the start of treatment, weight restoration is a critical first step. Without this, recovery just isn't possible. Working closely with the nutritionist, calorie consumption is gradually increased from a little over 1,000 calories a day to upwards of 4,000 calories daily in order that the patient gains about 1 pound a week as an outpatient and about 2 to 3 pounds a week as an inpatient. For those severely underweight, particularly with a BMI of less than 16, close monitoring is necessary for refeeding syndrome, which results when the body switches from catabolism to anabolism and can lead to shifts in electrolytes, particularly the movement of phosphate into cells, resulting in hypophosphatemia. This can have serious consequences, including cardiac arrhythmias, heart failure, seizure, and death. During weight restoration, we begin to address the maladaptive eating behaviors. These patients have a lot of issues around what they eat, ranging from severely restricting the types of foods consumed to eating incredibly small portions, avoiding fluid intake, and completely ignoring cues of hunger and satiety. They may have elaborate rituals around eating, such as cutting their food into tiny pieces or eating incredibly slowly. We also address compensatory behaviors like excessive exercising or purging. To do this, patients work closely with a nutritionist to come up with a meal plan, setting goals to gradually expand what they eat. This may involve keeping a food record or recruiting family members to help with accountability. They also come up with a plan around exercise, which may need to be cut out completely in some cases until weight is restored. In the inpatient setting, there are group meals for greater support and accountability, as well as group outings to restaurants and grocery stores, all focused on helping to normalize their behaviors around food. Interestingly, weight restoration itself leads to a decrease in many of these behaviors. As food choices gradually increase, hoarding diminishes, and obsessions around food decreases. However, certain aspects take longer to resolve, particularly the distortions around body image and tendency for excessive exercise seem to take the longest to improve. In addition to directly changing behaviors, we also do therapy to address the underlying thoughts and feelings behind these disorders. For adolescents with anorexia, the treatment with the most evidence-based is family-based therapy. Parents take an active role in this form of treatment, learning to support their child through the process of recovery. For adults with anorexia, the data is less clear, but studies repeatedly show that including some form of therapy with the nutritional counseling is better than just nutritional counseling alone. There is evidence for a number of different types of therapy, and most therapists use a combination of approaches to help a patient. These include cognitive behavioral therapy, motivational interviewing, interpersonal therapy, dialectical behavioral therapy, and mindfulness. All work to help the patient develop new coping skills, tolerate and decrease emotional distress, and better understand their illness. For both bulimia and binge eating disorder, the treatment with the best evidence is cognitive behavioral therapy, or CBT. CBT looks at the interactions between thoughts, feelings, and behaviors and works to change problematic patterns. Finally, let's touch briefly on medications. Generally, meds are of limited efficacy in eating disorders, but can be helpful in some cases, particularly when there are other psychiatric issues in the mix. No medications are approved by the FDA for treatment of anorexia. While SSRIs are fairly ineffective in the low-weight state, there is some evidence that antidepressants help prevent relapse. We also sometimes use antipsychotics, but patients tend to not like them, particularly when we have to inform them that weight gain is a common side effect. Also, frankly, results on them are pretty mixed. For bulimia, SSRIs are first line, and Prozac is actually FDA approved. Do not use Wellbutrin or bupropion, given the increased risk of seizures in the setting of electrolyte imbalances. This is a classic test question, so keep that in mind. SSRIs are also first-line treatment for binge eating disorder, and Vyvanse, or lisdexamfetamine, is FDA approved. However, in the end, we frequently tell our patients that food and normalized eating patterns are really the best medicine for the treatment of eating disorders. For some, medications may actually not be necessary. I just wanted to end this talk with a few comments about recovery. These patients do get better. While about 20% may develop chronic illness, between 60 and 80% improve significantly or make a complete recovery. However, it can take a rather long time to see these gains. Looking at anorexia, you see recovery rates approaching 80%, but only if you look out a decade from the initial onset of illness. When treating these patients, it's important to keep this in mind. Progress can be slow and is not always linear, but with your help, these patients can go on to lead full, successful lives. To conclude, treating eating disorders is a team sport, and early diagnosis and treatment are associated with better outcomes. Treatment for anorexia focuses on weight restoration and therapy. For bulimia and binge eating, SSRIs and cognitive behavioral therapy have the best evidence. Finally, remember the majority of these patients do get better, but it takes time. Thank you for your time.